One of the most important considerations is to familiarize yourself with the set contents before commencing the procedure. You'll require an orange needle, a green needle, a 10 ml syringe of local anesthetic. The tray contains a number 11 scalpel, a 10 cm dilator with adjustable safety stop set at 3.5 cm, a guide wire insertion needle with 1 cm markings, a stainless steel guide wire with introducer to straighten the tip, a chest drainage catheter, a 10 ml syringe loaded with 3 ml of local anesthetic agent, a 3-way stopcock with cap, a funnel and fir tree tubing connectors. During initial infiltration, the green needle is used to assess the thickness of the chest wall. The measurement can now be transferred onto the guide wire insertion needle. Remember to add half a centimetre to ensure clearance of the parietal pleura. The dilator is supplied with a safety stop set at 3.5 centimetres. This stop should be adjusted to the chest wall thickness, with 1.5 centimetres added to ensure the full diameter of the dilator passes through the parietal pleura. The latest dilator now has a removable guard set at 5 centimetres from the tip. Here we see the traditional 20 centimetre dilator, the 10 centimetre shorter style supplied in Medical Seldinger kits, and the latest guarded version. In this example, a standard 20 centimetre dilator is being placed without proper attention being given to the depth of insertion. It's immediately clear that the dilator has been inserted too far, with potentially serious consequences. Here we see the latest guarded version. First, confirm the diagnosis with an X-ray or ultrasound scan. Prior to commencing the procedure, always ensure the chest drainage bottle has been correctly primed and is ready for use. Identify the correct insertion point. Particular attention should be paid to the safe triangle, as recommended by the British Thoracic Society. The area should be cleaned with an approved antiseptic solution and draped appropriately. Supporting the needle with one hand, infiltrate the skin and subcutaneous layers with local anesthetic. Aspirate during infiltration to avoid accidental injection into a vein. Entry into the pleural cavity can be detected by sudden aspiration of air. Note the depth of entry. Using a number 11 scalpel, make a 4 to 5 mm incision into the skin. Attach the syringe to the needle and, marking the required depth with your finger, insert the needle into the pleural space. Puncture of the parietal pleura can be sensed by a slight loss of resistance. Confirmation of entry into the pleural space is confirmed by aspiration of air and/or pleural fluid. Detach the syringe. Angle the needle to direct the guide wire towards the apex of the pleural cavity for a pneumothorax, or the base for fluid drainage. Straighten the tip of the guide wire with the introducer and insert into the hub of the needle. It must be easy to pass and should meet no resistance in the pleural cavity. Insert the wire to the marker and then carefully withdraw the needle, ensuring the guide wire remains in place. If not previously done so, set the sliding stop to the correct position before insertion. Pass the guide wire into the tip of the 10 cm dilator and insert with a rotational movement. Do not insert beyond the safety stop. Carefully remove the dilator, leaving the guide wire in place. With a rotating action, carefully insert the catheter into the pleural cavity. If resistance is met, remove the catheter and redilate the track. The pleural drain can now be connected via a 3-way tap and fir tree connector to a drainage system such as the Rocket Blue bottle or the Rocket ambulatory drainage bag. Secure the drain with a silk suture on a large curved needle. Avoid the use of gartering as this method tends to slip. Tie sufficient loops to secure the drain without occluding the tube.